All right, everyone. Well, thank you for joining us today. My name is Rachel Volpe from the New England QIN-QIO, and I will be your moderator for today's webinar, Chronic Care Management, Returning Independence to Your Patients with Cardiac Disease. Before we get started, just a few housekeeping items. This call will be recorded for training purposes. I'll be providing you details on accessing the recording at the end of this webinar. The phone lines will be on mute for the duration of this presentation. And if you haven't downloaded the slides, I have put a link in the chat where you can find the presentation. Throughout the presentation, you can enter any questions in the chat box on the bottom right-hand corner of your screen. Please make sure to send questions to all participants, and we'll be going over the questions at the end of the presentation. I will now pass this over to Marissa to introduce us to our presenter today, Kathy Roby.
Thank you, Rachel. Good afternoon, everyone. Kathy Roby is the Connecticut State Lead for the Cardiac Health Initiative with the New England QIN-QIO. Ms. Roby specializes in teaching and educating nurses, focusing on improving home care provider clinical outcomes and reducing acute care hospitalizations for Connecticut home care providers. And with that, I'll turn it over to Kathy.
Thank you, Marissa. I hope that the sun is shining everywhere today. I don't know about the rest of you, but I am pretty sick of rain. I'm beginning to squish when I walk. It's finally sunny and warm, so I know we all have spring fever and we'd much rather be outside, but I hope you'll give me just a few minutes so that we can talk about chronic care management once again. I know that back at the beginning of the 11th scope of work, we did have a couple of other programs where we talked about chronic care management and using this methodology of interacting with our patients with cardiac disease, with diabetes, with lung disease, and with ongoing underlying depression. This is a system that does work very well. And although we will talk about applying it to patients with cardiac disease today, its principles and its process are equally transferable to almost any chronic illness that your patients may be dealing with. Our goals for our time together today will be focusing on these 4 items. We're going to initially frame everything in terms of reducing your acute care hospitalization numbers. We want to, alongside that, reduce emergent care events. If we can keep our patients at home, keep them out of the emergency room, keep them from being readmitted, it will make a significant difference for all providers. We want to improve their outcomes. It's not enough for them to stay at home and stay out of the emergency room. It's equally important that our patients have positive quality outcomes. While we're doing that, we want to enable our patients to achieve what is called self-management of a chronic illness. We want them to transition in their own minds from becoming the heart failure person to going back to Ann Jones, a very nice lady who lives and enjoys every day that she has. How are we going to get there? How will we achieve these goals? They're pretty lofty things. Taming readmission rates and emergent care rates has proven to be rather more difficult than many of us expected, especially now where many of you have rates that are within spitting distance of the national, maybe a hair above or a hair below. Making progress now is 10 times harder than it was when you were 5% above the national. So to get there, by the end of today's program, I'm hoping that you will understand the significant difference between nurse case management and patient self-management. That you will understand how to go about teaching and enabling your patients to self-manage using the strategies we will discuss. That you'll understand why patient self-management effectively increases patient adherence and reduces hospitalizations. You'll understand and recognize the connection between this care model and increasing your patient satisfaction and improving your outcomes. And if you remember, reducing readmissions, improving patient satisfaction, improving your outcomes, when you add them all together, you can add another star onto your 5-star rating. You can increase your reimbursement. This is going to touch every aspect of your agency's daily process. From our patient's perspective, why is this so important again? Because patient self-management, when your patients feel that they are in control of their own lives and their own bodies once again, will improve their satisfaction with your care, with your agency, and with themselves. It will improve the quality of care that you're providing to every patient that you touch, and it will significantly improve the outcomes. When you are looking at outcomes in general, but when you look at the outcomes related to readmissions, emergent care, and those tied to congestive failure. Patient self-management also is going to have the additional impact of bringing care planning, care coordination, and clinical documentation into full compliance with the newest versions of the COPs. And lastly, perhaps most important to many of us who have managed teams of nurses, your personal satisfaction with the work that you do will increase with your degree of success in working with your patients. And you could once again find that satisfaction that you've been seeking since the day that you put on that pin and stepped out into nursing. It all sounds wonderful, doesn't it? So where do we begin? How do we make the transition from this nurse case management model to patient self-management? To do that, we're going to need to develop some new skills and enhance the ones we already have. We'll be using some new things in our toolkit in working with patients. We'll have to take a slightly different approach to how we do patient education and how we document it. And we will need to transition from our current model to providing self-management support, because we are going to be placing the patients where they belong, in charge of their care plan, in charge of their own bodies, in charge of their own well-being. What are the tasks that are included in patient self-management? We want our patients to understand their condition. Today we're focusing on heart failure, but it could well be diabetes, lung disease. It could be fibromyalgia. It could be any number of things. Whatever the long-term illnesses that they are dealing with, they need to understand what the symptoms are, what's going on, and what it means to them. They need to be able to manage the medications themselves as independently as any other comorbid conditions will allow them to do. We want them to know what the adverse signs and symptoms might be, and to be able to recognize them, not when those adverse symptoms have suddenly reached crisis. It's 2 in the morning and we're dialing 911. Instead of notifying you 3 steps earlier, when they can call you at 9 in the morning and say, I gained 3 pounds. Not just today, but yesterday. I don't feel so good. And you can have a nurse there almost immediately. We want them to respond correctly, timely, to those signs when they learn to recognize them. Calling for help, whether they're still calling you because you're still involved, or whether they've transitioned to being able to call their physician themselves and say, I think I need to be seen because, and having the information to provide directly. And this will transition them. If you are successful in having them finish their episode with you and transition to complete self-management, they'll be working directly with their healthcare providers, with their cardiologist, or with their family practice, with whomever they are working with. We need to give them the tools so that they can do that directly. How would you define self-management support when your patient is accomplishing these tasks and you are helping to support them? What does that support look like? It's defined as the provision of education and guidance to increase a person's skills and confidence in the functions of self-management of chronic conditions. So we can say that this is not confined to heart failure, lung disease, diabetes, and depression, even though the first three are the primary causes of readmissions and emergent care and are most often in the elderly population predisposed by underlying long-term depression. So if that's what we're going to head for, if we're going to provide the education and the guidance, we're going to get them to the point where they can manage themselves with self-management support. How are we going to do that again? There are specific things that you either have in your toolkit that you use on a daily basis or that you may need to acquire or expand. In our toolkit, in doing patient self-management, teaching the self-management of chronic care conditions, you will need to work on your interview skills, taking what may be a slightly different approach in one-on-one conversation. Clinical knowledge will need to be accurate, in-depth, and probably expanded because we are learning new things every day about long-term chronic illnesses. So your clinicians need to be current and well-prepared. That includes being always well-informed about new medications. Remember, on your patient satisfaction survey, go back and take a quick look. One of the critical questions that will inform patient satisfaction scores was, did your nurse seem knowledgeable about your current medications? Did your nurse seem well-informed about your condition? To improve your score on that patient satisfaction, you need to have well-founded, expansive clinical knowledge. You need to be able to create, based on that knowledge, focused assessment formats. Your assessment skills need to be targeted and hone in right on the adventitious signs or symptoms your particular patient may display with the particular chronic illness you are trying to deal with. You need to have teaching and training materials that are specific to the condition you are addressing. When we talk about congestive failure today, we'll be using terms like DASH diet, the Mediterranean diet, reportable parameters. Those are the things you're going to need to have ready to go. Medication flashcards, whatever your agency uses for your teaching and training materials, these are the things you're going to need to be sure are focused and updated. Tools and resources will be critical. What kinds of resources do you make available to your clinicians? For being up to date with medications, there are currently no less than 7 free apps for your smartphone to make it even smarter. You can pick one of those, download it on your phone, and you will always have immediate access to all the information that you could possibly need about the newest, most current medications. Those are some of the tools that are out there. They are not going to cost you money. They're going to sit there and be right at your fingertips, literally. Other resources that we will provide are at the end of today's presentation, and they will give you links to where you can find additional materials that you might need. If you remember, in the new COPs, we all rolled our eyes when we saw a patient-centered team will meet to direct the patient's plan of care. But you know what? That's what chronic care management is all about. How are we going to improve the condition of a chronic heart failure patient if we don't involve the PT and the OT in making that plan? You're going to need the PT to develop a cardiac strengthening exercise plan that the patient will not only learn, but actually want to do and actually do. And the OT is going to teach energy conservation, the most efficient way to do this so that you won't get short of breath and you will still want to do it. So those are all the different things you're going to find in your newly revised toolkit. So let's start our walk around that circle and look at the different pieces in that toolkit. Interview skills. I don't know if you remember, but motivational interviewing is a term for a way that we can interact with our cardiac patients and, as I said, any other patient with a chronic illness. Motivational interviewing refers to a four-step process. What you're going to be doing is beginning by expressing your empathy. And I'll give you some examples, but we are talking about using always open-ended questions that can almost never be answered with a simple yes or no, shutting the door on future conversations. So open-ended questions that express your empathy and understanding. You want to develop the discrepancy. Acknowledge your patient's perception of what happened. And we'll identify some of the more common ones so that you can acknowledge the difference between what the patient thinks happened or thinks is happening to them now and what's really going on. We're going to roll with the resistance. The patient who says, I'm sorry, but I haven't exercised in the last 70 years of my life and I'm not going to start now. That resistance. The only time I see my grandchildren is when I have pizza with them on Sunday afternoon. I'm not going to give it up. We need to do what we need to do to find out how we can adapt what it is that our patients want to do with what they can and should do by acknowledging it, rolling with that resistance, and identifying what they're willing to trade in order to still do what they've always done. We need to support their self-efficacy. We need to help them to realize that just as they were independent, self-supporting, self-managing adults when they were 25, that they can be just as independent and self-managing at whatever age they are today and tomorrow. Let's look at some examples. When you are asking those open-ended questions, let's take that 80-year-old patient with ongoing stage 3 congestive heart failure who was in the ER with chest pain that came on at 3 in the morning, spent 3 days in the hospital getting totally diuresed, and is now back home talking to you, and you can see the top of the chip bag sticking out of the knitting bag. You want to ask them to tell you about what brought you to the hospital. I understand you spent 12 hours in the emergency room. What was that like? Let them tell you. Let them begin their story. They are eager to tell you all about it because I'm sure there were things that they are still angry about. The nurse with the cold hands, the doctor with the cold stethoscope, the people they couldn't understand because they don't speak English very well, and all the things that made them scared and crabby and anxious. They want to tell you, and as they're telling you, you can begin to ask some other open-ended questions. When the patient says to you, I woke up at 3 in the morning, I thought my husband was sitting on me. I couldn't breathe. That's the time to say, that must have been so very frightening. And what do you think might have caused that to happen? Let them tell you what they think is causing these symptoms of theirs. And when you do that, you can begin to ask them what they know about their current condition. What does it mean when the doctor tells you you have heart failure? When you look at the questions on this slide, this is not how you want to ask them. These are the questions you want to ask, but you're going to need to say them differently. If you sit down with a stressed, short of breath, definitely frightened, older person, and you say, what does the diagnosis of having heart failure mean to you? Really? I don't think they're going to answer you. They're just not. They're going to give you oh, I don't know, it just means I can't do anything I want to do. You need to find open-ended, fifth grade level ways of asking the questions so that they will feel comfortable saying, well, you know, he keeps telling me that, but I have no idea what he's talking about. And I tried to ask him, but he's so busy, and he had to go. So, can you tell me what that means? You're going to get much farther in patient education if you can ask the questions in a way that acknowledges the difference between what they think they understand about their condition and what's really going on, and finding a way to explain it to them that they will understand. I want to give you a really good example. I know someone who at a fairly young age developed a sudden onset of a cardiac condition. In our terminology, it's a conduction disorder with a dysrhythmia. From the patient's perspective, I passed out, woke up on the floor with people pumping on me, and I had no idea what happened. Gave me a headache when I hit the floor, with no concept of exactly what happened. In the course of the diagnosis, this person saw a regular cardiologist, a cardiac surgeon, and an electrophysiologist. But it was the electrophysiologist who finally sat down with a piece of paper and a felt tip pen and said, let me put it to you this way. Dr. A that you went to see is a cardiologist. He's a plumber. His job is to make sure that all your blood vessels stay open, just like the pipes in your bathroom. He keeps them open so that things can flow through, like the blood and the oxygen that you need. The surgeon, well, he's a carpenter. If things get plugged up, they get twisted, they get broken, he gets in there and he fixes them. Now, you know your house needs wiring. It has fuses, it has circuit breakers. That's my job. Your heart has its own fuses and its own circuits. I'm an electrician. My job is to get in there and make sure that those things work the way they should. Think about that the next time you're trying to explain to someone why their doctor said they needed a pacemaker. It's going to make a whole lot more sense to a 78-year-old retiree who's tired, short of breath, and confused when you explain it that way. You need to find out from them what they hate the most about this new diagnosis. You want to ask them, what does making these changes mean to you? Do you think that if you take all the medications, if you change the way you eat, it's going to make a difference in your everyday life? You may find that somebody's going to look you square in the eye and say, I open my paper every morning and the first thing I look at in the Hartford Current is, who died? Because I'm losing all my friends, and they can't drive anymore. So why would I want to live longer when living's not very much fun? How will you answer that question? You need to be able to address the underlying caution, the underlying stress that your heart patients are feeling, to find a way to motivate them to want to take the medications, to want to change their diet, to want to walk around the house because they have a goal. If you ask your patient, do you have a goal? They're going to look you in the eye and say, you know, for years my goal was to get to retirement. I got here and it's not looking so good now. You really want to think about what it is they want to trade for to make these changes. Their new goal might very well be to be able to go to their granddaughter's wedding. Maybe they can't dance, but they can be there. We need to help them to make the connections between our treatment plans and their new goals in life. To play with a grandchild, to see that grandchild born, to walk someone down the aisle or see them get their diploma. And then we want to help them to figure out what's getting in the way of their ability to change their diet, to take their medicines, and stick with the doctor's plan that hopefully he's making with them and not for them. So we work on identifying what's different about what they understand and what they should know about their own condition, about their own body. We address those knowledge deficits by using the example I gave you of a way to teach your cardiac patient about how their heart is functioning and what it is that needs to be addressed. You can use that example, that parable or fable, if you will, to show them this medication is going to help the plumber keep your blood vessels open. This medication is going to keep the electrical circuits working. However you choose to do it, find something that will make sense and you can remedy knowledge deficits far better. You can identify the areas of non-adherence. They still love that pizza. They still want to go out for Chinese because that's what my grandchildren eat and I want to go with them. And help them to figure out what they're willing to trade. Get a sample menu from their favorite restaurant and literally sit down with them. That's an absolutely valid means of a billable visit with patient education. You maybe were sitting there with the menu for Movie Tuesdays, helping them pick out what they could eat so they can go out with their friends. But when you chart it in your records, you are doing diet teaching and getting a 50% teachback of appropriate food choices. They're the same thing. It's just a little bit of a different language. And you've identified what this person is willing to trade in order to accomplish their goal, out to dinner with friends, and your goal of diet compliance. This becomes the basis for your plan of care, a patient-centered, patient-focused, patient participatory plan of care that meets the conditions of participation and will give you a compliant, educated, involved congestive failure patient. And this will give you the ability to create smart goals in a way that you've never done before. Let's think for a minute about what a SMART goal is. We're going to go over the definition of that once we figure out how to get past all that resistance we're getting. Remember, when you went to open that patient's record, you saw the top of that chip bag sticking out of the knitting bag, right? I know I've interviewed more patients with all kinds of goodies hiding under a skein of yarn. That resistance, that reluctance to change is your target in almost every plan of care you make, regardless of the diagnosis. You need to figure out where that ties to the patient's goals. If your patient's identified number one goal is, I was so miserable in the hospital, I never want to go back there again. But I really don't like the diet they gave me. It was terrible. The food was bland and cold and tasted terrible. So we need to address that. I don't want to go to the hospital, but I want to eat what I like. I hate it when I feel like I can't breathe. But I don't really see that what I eat has anything to do with that. And I haven't exercised since I was a kid, and it's boring. And I don't want to do that because I don't like to go to the gym because I don't look like those skinny young people that are over there, and I'm so embarrassed, and I can't do that. So we need to find other ways to do that. If you really wanted your patient to walk for 30 minutes a day, tell me, please, what is the difference between going outside and walking on the sidewalk where the blocks of concrete are uneven and we could very likely be on our nose any old time, or I know that your stories are coming on at 1 o'clock. When the commercial comes on, all I need you to do is to get up from the chair, walk the full circle around your house, plot out the route, and while the commercials are on, just walk around maybe once, twice, however many times the commercials last. When the show comes back, you sit right down and enjoy your story. Now, you know and I know, there's more commercial time than there is story on TV these days. By the time they've walked through every commercial set, they will have walked their half an hour, especially if you can get them to do that for 2 or 3 of their soap operas. And some of the time, you've accomplished the objective. So how did you do that? You established a SMART goal. Your patient verbalized what they want to accomplish. I want to be able to walk around without being so short of breath. Okay, we're going to do exactly that. You're going to walk around 3 times around the route in your house during the commercial. And you're going to do it all through your next 3 stories. You're going to rephrase what they're telling you into that goal. So what is a SMART goal? It's very specific. I'm going to get up and walk. It's measurable. 3 times around this route in my house. It's something that can be accomplished. It's reasonable. It's not out of the realm of possibility. And it's time sensitive. I'm going to do that today and every day this week until you come back on Friday. We then take that goal and rephrase it into our terminology to put on the 45 in the orders. And where does this get us? By using that means of communication, by creating a plan with our patient, and using the SMART goal process, we now have a person, not a patient, but a person who is able to identify and verbalize what they want to accomplish, what the changes they're going to make, what they're going to do, and identify the how. You can use the exact same process to teach your patient how to recognize a symptom. I do not want to get short of breath again. How am I going to do that? Specifically, I'm going to weigh myself every day so that I will know if I gain more than 2 pounds in 24 hours. That's recognizing a change. How do they identify the cause? Because you're teaching them about the salt that's the content of what they're eating. That quite possibly, if they get their chips that are the unsalted Pringles ones or that are vegetable chips, I thought that was the worst idea ever. And then, I bought them, and I actually like them better. They have flavor, and they're colorful. They're kind of neat. Get your patient to try them. So that's identifying why they need to do it, making the change, and then evaluating themselves the effectiveness of that. So that's the process that you really want to use. By doing that, what you're accomplishing is you've established the ownership of that plan of care. Remember, in one of the very first slides, we talked about making the transition from nurse case management to patient self-management. Who owns this plan of care? When you first went into school, into nursing school, into physical therapy or occupational therapy class, one of the first assignments you got was a patient scenario, and you were told to go home, write yourself a care plan, and bring it back to turn in and get graded on. And we all wrote these lofty 5, 6, 10-page plans of care. They had all kinds of things in there that our perfect A-plus patients were going to do. So who owned that plan anyway? We did. After all, we were the ones getting graded, right? So we wrote those plans about how we were going to change our patients' way of diet. We were going to get them to follow a 2-gram sodium, low cholesterol diet, yada, yada, yada. And do you really think that any patient that you presented that 5-page plan of care to was going to do anything with it? Let me tell you what my mother did after her fractured hip. The therapist that she had the first go-round, when she was all done and my mother could walk her 100 feet with just a straight cane and to get in and out of the car and was dying to get her keys back, she was given a 3-page set of exercises to do long-term after she was no longer on Medicare. The therapist shook her hand, reminded her the satisfaction eval was coming, and walked out the door. The door closed. My mother picked up the 3 pages of exercises and promptly dropped them, not in the drawer, in the trash. So when we own the plan of care, where do you think it's going to end up when we're not there? It's going to be at the bottom of the drawer or the bottom of the recycle bag, but it's not going to be in our patient's hands. It needs to be their plan. It needs to be their personal plan, their goal. What are they willing to trade in order to reach it? I want to be able to walk with my new grandson. The exercises will help me to do that. I absolutely do not want to go to the ER again. If I take the water pill, I can avoid that. We want it to be their goal and their plan. To get there, they need to understand what it is that they are trying to do, and they need validation. That is one of your most critical roles as the nurse case manager. You want to support, remember, patient self-management support. You want to support their need to change and validate the things that they are doing right. This requires you to take the needed information, the needed behavior change, and the self-assessment into increments your patient can handle. Many studies have been done looking at the impact of the stress of a trip to the ER, especially when it ends up with 48 hours in the holding pattern, or spending 3 or 4 days in the hospital. It's been demonstrated that you can take a PhD college professor, park them in the hospital for 5 to 7 days, send them home stressed, exhausted, and dying for their own coffee in their own kitchen. And when you arrive to do your 120-page OASIS questionnaire and your assessment and all your education and all those forms you need signed, and they're going to be not able to concentrate for more than 20 minutes, not able to understand or retain anything above a 5th grade level of understanding and processing. Stress and fatigue. Those are the things that you're battling. You need to take what you're trying to teach, break it down into increments, and then let your patient be your guide as you teach it, and then have them teach it back. And what is teach back? It's whatever you have taught to the patient and or caregiver and having them teach it back to you. Not just the day you taught it, but the next visit. Clinical documentation of the patient education and teach-back process needs to include what you actually covered today, the percentage that your patient and or caregiver was able to teach back to you, and what the impediments to success were, what your next steps are, what you're going to teach next, so that you can take helping your patient understand what it means to say that they have systolic heart failure. What does that mean to them? So you're going to need an analogy that they can understand. Bring back my friend the carpenter again, and the plumber, and the electrician. Draw a picture so that you can teach it to the patient, then they can show you how they will explain it to their grandchild when they're trying to explain why Nana is a little bit slower helping you to get your toys out of the box. And then you document what they were able to teach back today. What is the problem? They're fatigued. They still have a headache. Their blood pressure is still too high. These are the impediments. This is how you're going to justify being able to continue to make additional visits. So you break it down into bite-sized pieces, teach it today, have them teach it to you on the next visit. But certain things need to be done every visit. What is your patient's rescue plan? If I gain 3 pounds in 24 hours, I will record it on my calendar, I will call my doctor or my nurse, and then I will make the medication change and then reweigh myself and call them back. They need to know what their rescue plan is for their personal change in condition plan, just as it's outlined in the COP. Do you use the stoplight tool, where you have green information? If these things are happening, you can wait till the next nursing or doctor's visit to discuss it. If the things in the yellow zone are happening, you need to call somebody now. If it's in the red zone, you need to call 911, but then you do need to call your nurse or your doctor to make sure they know what's happening. You're always going to teach them the critical self-management things need to be reinforced on a daily basis. Let's talk a little bit about our clinical knowledge. We need to be able to define heart failure. Can you define the clinical syndrome that could result from any one of the dozen different structural or functional cardiac changes? We know that the primary causes for heart failure are coronary artery disease, hypertension, cardiomyopathy, from a variety of causes. Patients are now classified with systolic and or diastolic failure, the emptying versus the filling of the different chambers in the right order. We need to be able to define and explain in language they can understand the most characteristic symptoms of fluid retention, shortness of breath, fatigue. We need to also be able to explain and really define the different ways that angina might manifest itself, that other exacerbations might manifest. This is why you need to have absolutely strong clinical knowledge. What do you know and understand about current treatment guidelines? And can you teach these things? What about the most current used medications, the diuretics? What are the new modalities, the new philosophies of salt-restricted, low-cholesterol diets? I mentioned the DASH diet and the Mediterranean diet before. These are readily available to you online. Google them up, print them, and you will find this is a much more effective way of achieving diet compliance for your patients. Do you know all the things you need to know about ACE inhibitors? What about the ARBs? Do you know which is which? And do you know what the difference is between how they work? You're going to need to be able to explain it and teach it in a way that your patient can understand. They are not going to understand angiotensin receptor blocker. They need to understand what that means and how it happens and what their drugs do. Beta blockers, aldosterone antagonists. What about that exercise training? Remember, if they walk around their own house in a loop for 5 minutes, every 10 minutes when the commercials come on, you're accomplishing the same thing. What about those NSAIDs? We know that arthritis and heart disease are inextricably linked. The mechanism is not well known, but we know they have a relationship. We also know that many, many people are self-treating with over-the-counter NSAIDs. And they don't understand when their doctor says, I want you to avoid you taking any of the over-the-counter NSAIDs. Really? They don't know that that means don't take aspirin, don't take Advil, don't take Aleve. They don't know that. You need to be able to teach that to them. Take the bottle right out of their medicine cabinet and show them what it says on the bottle so that they will know how to make the right decision. What are some of the caveats that we can always have to keep in the front of our mind? Those patients with anemia or kidney failure are more likely to experience rapid swing exacerbations of their illness. Patients with kidney failure will tend to lose iron, to become very anemic very quickly. And you want to be sure that they understand that if they are more short of breath this morning, that if they don't call the doctor and deal with it now, by 4 o'clock they could need the emergency room. So you want to be sure that you are bearing this in mind as you are teaching. We spoke about the relationship of arthritis in the heart failure population. Make sure that you actually show them the NSAID bottles, Advil, Aleve, anything in that family, because it's important they know what to look for and not purchase in the local drugstore. We mentioned early on, when you're talking to your patient, we ask them about their goals, and they tell you, what goal could I possibly have? I opened the paper this morning after I came home yesterday, and I looked and saw that one of my best friends from childhood died yesterday. What do I have to live for? I don't have anybody to go out to lunch with anymore. Depression is most often, to one degree or another, an underlying issue with your heart failure patients. If you're that sad and lonely, what earthly reason is there to take all these damn pills? Excuse my French, but that's what they're going to tell you. What do I need those for? I don't have anybody to go to lunch with. I don't have anything to look forward to. All I do is look in the paper to see who died already. You need to find a way to help them identify a new goal. Look at the pictures around. Focus on the children, the grandchildren, the events, the next holiday that's coming. Find something that they are interested in doing, in making it to, and you'll help them to find a goal and get a handle on that depression. Remember that most often when they see their physician, the question is not being asked as to whether or not they are exhibiting any symptoms of depression. And if somebody asks you directly, do you think you are depressed? What are you going to say? You're going to say no, because you don't want anybody to think you're crazy. And older patients, the more elderly, the more common it is. They see any time they are admitting to being depressed as admitting that they have mental problems, and this is a bad thing, so I'm never going to say that. Rather, we should ask about their sleep patterns. Do they have difficulty falling asleep, staying asleep? Do they sleep all the time? Do they really have no interest in eating or walking or reading a book? These are the evidence of depression in this population. Screen and monitor and help them to get the treatment they need to make it a positive thing to go forward with sticking with those medications, the walking around the house, and the swapping out of one thing for another in their diet. These are some of the most common medications that you want to be absolutely familiar with. But you also want to be really familiar with the brand new ones that are advertised on the commercial at the 6 o'clock news. So that's why I recommend you have one of those apps right there on your phone. so that you can, when the patient says, I'm going to ask my doctor if I can take that, right there, that commercial. See that drug? I want that, because that person looks pretty good and I want to look like that. You need to be able to call that right up on the drug app on your phone and talk to them about, well, this is used for this particular illness, and that's not quite the same as what you have. So here, let me tell you how it works, and then certainly go ahead and ask your doctor when you see him, but this will help you to understand what he may say. Now, not only have you educated your patient, you've given him something to ask his doctor about, to engage the physician in a two-way conversation, but you've also shown this patient that my nurse is knowledgeable and comfortable with all the medications, increasing their satisfaction, potentially continuing to improve their outcome with adherence to their medication regimen. You've accomplished a great many things. A focused assessment is going to be critical. What causes a heart failure readmission? Fluid overload. Getting your patients to look at a DASH diet, a Mediterranean diet, so that they are keeping their fluid in balance. Adhering to their medication schedule. Notice I am deliberately avoiding that compliance word. I really don't like that word. It always sounds to me like somebody's going to send me to the corner. Compliance was never my strong point. And neither is your patient's. You want to find a way for them to want to take the medications on the schedule that you build with them. You want to identify what kinds of precipitating events might cause a heart failure episode to reoccur. We know there's a high incidence of coexisting renal failure. Any type of an infection is going to precipitate an exacerbation of heart failure, and stress is one of the biggest instigators. Along with dietary non-adherence, it will pop up anytime there's a major stressor, because nothing is more comforting than a piece of chocolate or a bag of chips. Trust me, I know. Who has the most control over all of these factors? Over not drinking a gallon of soda, over remembering to take those medications at dinner time and first thing before breakfast, over eating the right things instead of the want things. Our patients have that control, not us. And so we want to be sure that they're actually doing what they need to be doing. Your assessments are going to target those specific things. Every visit needs a full set of vitals with weights and edema measurements. You don't want to be looking at those ankles, giving them the eyeball, and putting in your notes 1+ non-pitting. You put 2 nurses in the room, and you're going to get 4 definitions of what 1+ non-pitting really means. Measure them. Every patient with their own paper tape in the home so that you can do proper ankle, instep, mid-calf measurements. Establish reportable parameters and stick to them. When the vitals or the weights or the edema measurements are outside, notify the physician. Help the patient to understand why you're doing what you're doing. And focus in on what the patient does or does not understand and how they're following that medication or diet. Patients and families can learn to do daily weights. You can teach them to use a one-person blood pressure cuff with a pulse. You can teach them how to juggle trade-offs here and there in their diet and medication daily plans. And you can teach them how to recognize the soft signs that are changes in how I feel that are all listed on the Stop and Watch tool. Here are some examples of what the parameters might look like for heart failure. While these are generally accepted parameters, you need to take these and customize them with your patient's physician so that they will be the one who knows best what time and when they want to be notified of a significant change and what a significant change is based on that person's track record. Think about how you teach medications. What does your agency use? Have you run all those tools through a learning level check? What methodology are you using? Do you know if your patient is an auditory learner or a visual learner? Do they need to see it and read it, or can they do it by hearing it? Do you have medication-specific flashcards? What about diet exchanges with pictures and lists? Are you waiting to do teach back? Are you having the patient now teach their spouse or their adult child so that you can get a better feel for what they understand and what you need to go back over? Have you given your patient a current list of all their medications? When was the last time you did a kitchen cupboard survey? You want to go through the kitchen with the DASH diet in your hand. Print it down from the internet, Google is your best friend, and then take a proper diet history while you stand in front of the cupboard. If you see 10-jar cans of canned green beans, you know you got a salt problem. You want to do this by avoiding conveying any sense of judgment or disapproval. Rather, teach the relationship between the canned green beans and the puffy ankles. You want to barter with your patients for balance between the must-haves and the can't have that anymore. Teach your patients how to wave the red flag. Use the stoplight tools that I referred to before. On our resources page, we'll show you where to find those. There are lots of medication assistance devices. Those pre-poured boxes, the ones that beep or flash, medication flashcards, the teach-back methodology, whatever you use that's most comfortable for you and for them, but we need to be educators above all else. I mentioned early on that this is a team approach. The COPs tell us that our patients have to be at the center, at the heart of the care plan. We're the team that provides the support. Our new role is to be our patients' educators, their partners, their cheering section, and their support as they progress to independence in patient self-management. So that's where we want to get them, and I'm hoping that today has been a positive experience for you. One of the hardest things about doing these kind of programs for me is that I don't get to see your faces, and I don't get to know if we're making a connection. I hope we have. I hope that if you have any questions, you'll feel free to reach out to me or reach out to your state lead. There is one for each state, and we all have access to the different materials. I want to remind you that the majority of these things that we talked about are available to you on the HHQI website at homehealthquality.org. You want to go there, look for the BPIPs, and select the ones on heart failure, on patient self-management, and you're going to find all the teaching tools you could possibly want. There's plenty of different things there. There's the DASH diet, the Mediterranean diet, medication flashcards, diagrams, stop and watch, stoplight tools. They're all there. So if you have difficulty finding them, reach out to Jenna or to me. We'll help you find them, and we'll help guide you through all the other resources that you could possibly be looking for. Okay, I hope that we'll hear from you, and if you have any other questions, reach out to us.
Thank you so much, Kathy, and thank you for everyone attending today's webinar. I know we are a little tight on time, so before we take any possible questions, I'm going to do some housekeeping items. A reminder that we are now on social media, so please visit us on Facebook, LinkedIn, Twitter, and YouTube. When you do close out of this webinar, the evaluation will automatically pop up on your computer. If you could please fill that out, we would greatly appreciate it. If you don't have time to fill out the evaluation right now, or if you're currently sharing your computer with someone else, you'll receive an email tomorrow with a link to the evaluation, as well as a link to the event page on our website. Again, I am putting the link into the chat for the PowerPoint presentation that Kathy just went through. Within the next few business days, the recording and the transcript of this webinar will also be added. Thank you again for attending, and I will open it up to any questions. I know we are at the time, or you do have Kathy and Jenna's information if you would like to reach out.
Hi, this is Marissa. I'd also just like to add that the link that Rachel posted also has links to some of the resources that Kathy had mentioned throughout her presentation. Hi, Roseanne.
Go right ahead.
Hi, Roseanne. We see your question for the HHQI resources. Those are on the link right above that Rachel posted. They'll be on the right-hand side.
Also, if anyone would like to ask a question over the phone, they can go ahead and press #6 to unmute yourself. That, again, is #6.
Hi there, this is Kathy. I wanted to thank the person who's the SASH coordinator. I'm glad that this was helpful to you. And as I said, the principles that we have are all transferable to any other chronic illness or situation that you're using.
All right. Well, I do want to be mindful of everyone's time, so we'll stay on the phone line for just another moment. And again, we did put the contact information back on the slide, so feel free to reach out to Kathy or Jenna if you do have questions after this presentation. All right, so with that, I will go ahead and end today's event. Thank you, everyone, for joining, and have a great day.